Hello everyone. Today's topic of discussion is diabetic ketoacidosis or DKA. DKA is an acute and potentially life-threatening complication of diabetes mellitus. It is characterized by high blood sugar levels in the blood, production of ketones leading to metabolic acidosis. DKA is commonly associated with type 1 diabetes, but type 2 diabetics are also susceptible. In 25% of patients, DKA presents a diagnosis of type 1 diabetes due to acute insulin deficiency. Also, if they miss their injections or they forget to take their insulin injections, they can present with DKA. Whenever diabetics undergo physiological stress, such as due to some infections or some medical conditions like myocardial infarction, post-surgery, or even emotional stress can cause DKA. Before we learn the pathophysiology of DKA, let me explain you the normal physiology first. Glucose is the major source of energy in the body. It comes from digestion of carbohydrates and is carried by the bloodstream to various organs of the body. Insulin is a hormone produced by beta cells of pancreas, and it is responsible for driving glucose into the cells. What happens is that insulin attaches to these insulin receptors on the cell membrane. This allows the glucose to enter into the cell through glucose transporters. So we can say that insulin acts as a key to open the body cells to glucose. When insulin is deficient, as in type 1 diabetes, the glucose cannot enter into the cells, so it stays in the blood, causing high blood sugar levels. Now that the cells of the body are starving because there is no glucose, the body increases the levels of counter-regulatory hormones in response to starvation. These hormones have two major effects that are responsible for clinical presentation of DKA. First is gluconeogenesis. It means that they produce more glucose in an attempt to supply energy to the cells. This is done by breaking down glycogen in the liver, a process called glycogenolysis, and by synthesizing glucose from non-carbohydrate substrates, such as by breaking down proteins into amino acids and lipids into free fatty acids. All of these contribute to produce more glucose via gluconeogenesis in the liver. However, as the cells cannot use this glucose because there is no insulin, this process only results in more sugar in the blood. The second process is ketogenesis. In the liver, the free fatty acid metabolism produces ketone bodies as an alternate energy source. There are three types of ketones: acetone, beta-hydroxybutyrate, and acetoacetate. Lipolysis also produces some inflammatory cytokines, the importance of which we will discuss in the next slide. Now that you know the pathophysiology of DKA, it is easy for you to understand the clinical features of DKA. Patients with DKA present with abdominal pain, nausea, and vomiting. That's because the inflammatory cytokines that were produced during the process of lipolysis irritate the gastrointestinal tract. Also, they present with polyuria, polydipsia, and dehydration. As the blood sugar levels exceed the kidney's ability to reabsorb it, the glucose overflows into the urine, taking water and electrolytes along with it in a process called osmotic diuresis. This causes large volume of urine, excessive thirst, and dehydration. Ketone bodies, unlike fatty acids, can cross the blood-brain barrier, and they serve as a fuel for brain during glucose starvation. They are, however, very acidic, and when produced in larger amounts, they overwhelm the buffering capacity of blood plasma, resulting in metabolic acidosis, which can cause confusion and even coma in patients with DKA. Patients with DKA may present with a deep and labored breathing. This is because the lungs are trying to reduce blood acidity by exhaling more carbon dioxide. This is called Kussmaul breathing or Kussmaul respiration. Acetone gives DKA patients' breath a characteristic sweet smell. Further evaluation of a DKA patient will show high glucose levels in the blood. Metabolic acidosis, arterial blood gases will indicate low pH and low bicarbonate levels. Urine dipstick will show ketones in the urine. Another compensation mechanism for high acidity moves hydrogen ions into the cells in exchange for potassium. This leads to increased potassium in the blood. But once insulin treatment starts, potassium moves back into the cells and hypokalemia may result instead. For this reason, the blood potassium level is monitored throughout treatment and potassium replacement is usually required. There are two different criteria to diagnose DKA. First is by American Diabetes Association and the second is by British Diabetes Societies. They're almost the same. They use the same factors, that is glucose, pH, serum bicarbonate level, and the presence of ketones in the blood and urine to diagnose DKA. There are slight differences in the level of glucose and serum bicarbonate between the two diagnostic criteria. Patients with DKA are severely dehydrated, so it is very important to start IV fluids as soon as possible. An intravenous infusion of insulin should be started at 0.1 unit per kg per hour. Once the blood glucose is less than 15 millimoles per liter, an infusion of 5% dextrose should be started to avoid hypoglycemia. As we mentioned earlier, that once the insulin treatment starts, patient can go into hypokalemia. Therefore, it is very important to replace potassium as required. That's it for today. I hope you liked the video. Take care. God bless you all.